I'm going to talk to you again about DMEK complications post-operatively, and fortunately this is not a very large topic because we haven't seen too many complications aside from graft attachment, which has just been discussed. So the main things that we see are pupil block, primary failure, rejection, endothelial cell loss, posterior synechiae formation, and cataract formation in phakic patients. So pupil block, as mentioned, can happen at the 2-hour mark or after that. So this is a photo from a patient who had a DMEK 2 hours prior, and you can see here that the edge of the pupil is well within the bubble, and they've got some peripheral shallowing and air behind the pupil pushing that area forward. So with this patient, I actually did a burp of air from the superior paracentesis. So how are we going to prevent this from happening? Well, all of our patients get dilated, as mentioned, with cyclopentolate and 10% phenol at the end of the case. Don't use myostat, it lasts too long, and don't use pilocarpine preoperatively. And should we be using a PI? Well, we've already had a bit of discussion about that. We don't use a PI. Other centres do, but we haven't found that it actually changes our pupil block rates. So how are we going to treat it? Know where your paracentesis is. If you can't find it, a useful thing to do is to put a drop of fluorescein on, and that will highlight where your paracentesis is. And you can use either the inferior or superior paracentesis. The inferior one you can use if you've got a very large complete airfill, and sometimes you can get enough air out. But actually, if you just gently touch on the superior paracentesis, enough air tends to escape to clear the pupil, and for some reason it just tends to be the right amount. If there's air behind the pupil, you've got a complete shallow AC, you can try to dilate the patient further and lie them down and recheck them after 30 minutes. We tend not to do that. We tend to just burp a bit of air. Primary failure, why does it happen? We think it's due to intraoperative graft trauma. The graft might be upside down in the first place, or we've actually just misdiagnosed a detached graft. How are we going to prevent that from happening? Use meticulous no-touch technique during surgery. Try not to traumatize your graft. Try not to expel the graft by pressurizing the anterior chamber relative to the outside world, and we've seen that can easily happen. And always use a letter to mark the tissue. As we've seen, it doesn't always scroll the right way. If you think your patient has a primary failure, we will always do an anterior segment OCT just to be sure that we're not missing a detachment that we're not seeing through an edematous cornea, and that gives the patient a chance of having just a rebubble instead of a reoperation. If you do regraft them, these patients still tend to do well as long as they haven't had chronic edema and scarring. One of the beautiful things about DMEK is the rejection rate is only 1%. And that's 5 times or 14 times less than DSEK and almost 20 times less than PK, depending which study you read. Despite that, we still maintain our patients on a daily dose of steroids long-term and indefinitely in most cases. The rejection looks slightly different to PKP rejection. So this picture at the top, there's a demarcation line here, which is a cataduced line, and edema relative to that area. With the patient in the photo below, this is a DMEK which is undergoing an episode of rejection. I'm not sure how well it projects there, but they've just got these fine KP throughout and don't get a cataduced line. But you treat it the same way. So our regimen is to use Durezol hourly for the first week and see how they respond. And our patients have done well with that. We haven't needed to augment anyone with peribulbar or periocular steroids or systemic steroids. Most studies show that DMEK has a greater endothelial cell loss than DSEK, but our own series actually shows the converse of that. We like to assess the viability of cells on the tissue when we're preparing it by using some vision blue right at the start of the case. And that will highlight areas where the endothelium has been damaged, and you can assess whether that graft is actually worth discarding or worth using. And we discarded a graft for that reason just a few weeks ago. The long-term survival rates, we're still not sure what the performance is going to be of DMEKs. Our oldest graft is 5 years old and they're still doing well. Dr. Mellor's just presented his 10-year patient and they're doing well as well. So the outlook is good. Posterior synechii occur when you've got prolonged contact of the air bubble with a small pupil. We maximally dilate. We don't use pilocarpine. We don't use myostat. And we haven't actually had any issues with posterior synechii.